It's a pleasure to moderate this nice symposium with Manos, and we will speak about OPN NC. So my first question is, how many of you have had experience with OPN NC? Can you please raise your hand? And who of you would like to use it but has not yet used it? Okay, so here. And how many of you work in the USA? I think you should come in the front. So maybe one short question. Why, though, for you, why have you not used it yet? Because it's not available, because it's in 250 hospitals already, or because you just feel still a bit insecure? So you are when you have it, you will use it. Okay, that's a good answer. Very diplomatic.
Yeah, well, I think you make a good point, Fiorim, that in the US people are not as aware yet about the availability and what it does, and a lot of confusion. I think the Victory trial will play a big role in increasing awareness, and we're excited to have you and Matthias present it later on. But maybe we'll just start and present a little bit the background of how this fits in the existing algorithms for modifying calcium. So the first talk, it's going to be with Dr. Matthias Bossard, who's going to talk about an update about the state-of-the-art strategies for plaque modification in highly calcified coronary lesions. Again, very busy operator. Congratulations on the Victory presentation, and looking forward to your talk.
Thank you very much for the nice introduction. Okay, let's do that. So, here we go. I rephrased the title of my presentation a little bit, and thank you very much for the introduction. My name is Matt Bossard. I'm an interventional cardiologist, and my focus is actually complex PCI. And what I would love to show you over the next few minutes a little bit, what are the implications of the Victory trial for our daily practice. And I hope that many of you in the room can take away a few points and reconsider how they perform lesion preparation in the future. Okay, let's get started, my disclosures. Just what you need to be aware of is that a large portion of interventional cardiologists still not adequately address coronary calcifications, and coronary calcifications remain one of the main reasons why PCI and especially stents still fail. They cause underexpansion, loss of stent integrity, malapposition, ultimately new intimal hyperplasia or new atherosclerosis, which in turn results in instant restenosis and stent thrombosis. Therefore, we need to address calcium. And as I just showed, the stent failure rate is actually rather high, more than 10% following 10 years. So, and now we have a big number of devices available, and usually a selection of those devices depends on operator preference or operator experience or lab preferences, whatever. But studies guiding us through or navigating us which device we should use are still scarce. And we have a lot of committees and experts who provide us complicated algorithms, how we should approach calcium. In my opinion, many of those algorithms, they're created in best intention, but they're just too complicated, or at least for myself, and I usually can't follow them. I'm a bit simple-minded, would my boss say. Okay, calcified lesions, as I just said, at high event rates, little randomized data, how to tackle that. Importantly, also to take into account is that the recent ECLIPSE trial suggested that NC balloons are probably the safer option than routine orbital atherectomy in calcified lesions. It is also important to note that the FDA approved the IVL based on a single-arm study which indicated that IVL is safe and potentially effective, but there was no control group, and I've stressed that already out on Sunday. So just to start, we need to rethink lesion preparation, and here's a just a simple example why we in Lucerne prefer the OPN over regular NC balloons to get you started. Here it's a lesion, heavily calcified, LAD, left main. You can see the angio here in the middle, how a regular NC balloon at high pressure performs here. It doesn't do anything. This lesion was ultimately only cracked with an OPN at high pressure, and here you see the difference, because when you inflate a regular NC balloon, not even speaking of a semi-compliant balloon, in the majority of cases you end up with duck boning, and the problem with duck boning is that you actually end up with this, and those are heavy dissections, spiral dissections, and in this scenario, when you lose the wire position, you're actually screwed. And therefore, I would highlight really that we should start no longer consider semi-compliant balloons or soft balloons in lesion preparation of very calcified cases. So for those of you who are not familiar with the OPN NCB, I'm going to talk about that in a few minutes. It's a very simple product, basically. It's just what it makes it different from all other NC balloons is it's double-walled, and it can stand very high pressure. You can actually, by IFU, you can take it up to 35 atmosphere, in reality probably even higher, and it has a very non-compliant uniform inflation profile, which makes it unique from all the other balloons. And I consider it as quite kind of a Swiss Army knife in the cath lab. So what we've learned early on is, here's some data from a registry in collaboration with the guys from McMaster. Natalia Pinilla had drafted that paper. We learned that the OPN could work very well in calcified cases. We saw there in a registry that you can achieve good stent expansion in a large portion of patients. And if you use it based on OCT measurements, you probably have very few perforations or periprocedural complications. That data encouraged us ultimately to launch a full-scale trial, the Victory trial, which we just published last Sunday. And this was a prospective randomized trial, including 3 sites with experienced OPN and IVL operators. We had blinded outcome from an independent core lab, and their patients were randomized. Patients with heavily calcified lesions were randomized in a 1-to-1 fashion to either OPN or IVL. Then they underwent stent implantation. Following stent implantation, the primary outcome, final stent expansion, was assessed, and all patients underwent follow-up examination at 30 days, and we'll continue to follow up those patients up to 2 years to learn more about long-term outcomes following rigorous lesion preparation with IVL as well as OPN. Again, it's important to also highlight that here for this trial, we made sure, or we were really concerned or meticulous in enrolling patients. We wanted to make sure that we include patients who have evidence of deep calcium, circular calcium, or basically heavy calcifications. And the protocol was actually also reviewed by the FDA early on, because we had the idea to launch a full-scale trial, including also sites in the US. For funding reasons, we couldn't do that, but they came back to us and defined, or in collaboration with the FDA, we defined the inclusion criteria, which were ultimately evidence of severe angiographic calcification, a calcium mark of at least 270 degree, or evidence of a lesion which would not be crackable with a regular NC balloon. So, and I've showed that on Sunday already. So again, like very calcified lesions. We also had 1/4 of patients had nodular calcifications, which are often considered the worst type of calcifications you can be dealing with, especially if you want to place a stent. What made, and that's my personal opinion, what made this trial so safe, or our approach so safe, is that we guided all the participating physicians on how to use the study devices, meaning OPN as well as IVL. We recommended to assess the vessel diameter with OCT, and based on those measurements, pick their devices. So for OPN selection, we were advised to downsize at least 0.5 millimeter than the actual vessel diameter, but not be reluctant in going to high pressure in case we have a small balloon. The procedural characteristics are highlighted here again. What we saw is that there was slight difference in procedure time, not statistically significant, but there was a trend at least. And we also learned that procedures involving IVL, they actually required significantly more devices in order to deliver the IVL. There was no statistical significance in terms of rotational atherectomy use. That's why I haven't highlighted the p-value there. That's a question or point which was brought up in the discussions following the publication of the results. And down here in red, you can also see that in this trial setting, we took the balloon, the OPN balloon, to very high pressures. Like in a median of cases, max pressure was around 40, which is considered very high pressure inflation. So stent expansion was the primary outcome. I would like to highlight that as well. So that's a very reliable and easily accessible parameter, surrogate parameter for long-term outcomes. And we decided to come up with that parameter because it can reliably assess and it provides you very good information about the whole implant or result of the stent. And also one of the reasons why we decided to go with OCT instead of IVUS was that OCT provides you more detailed information about the calcium, not just morphology, but also extent in comparison to IVUS. That's also one of the points which was already brought up in the discussions. Primary outcome, once again, OPN NCB was non-inferior to IVL. It was not superior to IVL, but non-inferiority was reached easily. And then we also tested and looked at a series of subgroups. The most important ones are highlighted here, including also nodular calcium formations. There's no significant interaction there. Also, following the publication, we had also additionally looked at if it made a difference, if we were using atherectomy up front. Also there, again, no significant difference. Safety outcomes, again, it's important to stress out, although the trial wasn't powered for safety outcomes, there was no significant difference between the two devices across all the different safety outcomes which we assessed, notably coronary perforations, which were rather low in both arms. Secondary outcomes, acute as well as procedural success, including safety outcomes as well as hard outcomes in terms of cardiovascular outcomes, no difference there. Strategy success with both devices high. So enough talking about data. Now I want to show you some practical cases before I conclude. Here I have an example of a patient who was actually enrolled into the Victory trial. This is what I call a 62-year-old male with heavily calcified coronary artery disease, diabetes. He basically had 3-vessel disease, but he declined CABG surgery, and therefore we were dealing with his coronaries with PCI. Okay, down here you can see on the OCT run confirmed heavy calcifications. AI by Ultron highlights that. And in order to deliver the OPN device, to be fair, we had to use a little bit of rotablation. We rotablated into the PLA branch, and following that, we used one OPN balloon and implanted a few stents. And here is how it looks ultimately. And we achieved a rather reasonable stent expansion here in that case. And for post-dilatation, we used one single balloon, which was a 4.0, a regular NC balloon, which we took up to 20 atmospheres. Basically, this procedure included 3 devices, atherectomy, one OPN, and 1 balloon to post-dilate, and that's the result we ended up. I think that's, from an economical standpoint, it's a reasonable result. Okay. Another case, a bit more controversial, it's one of our signature cases, and I've shown it elsewhere already, but I like to highlight it because it's a case which Florin did in a few years back, but to me, it's still so educational on how effective OPN can be. This is a patient who presented with a non-STEMI, was actually unwilling to getting a stent implanted because he was super reluctant on taking any medication on the long run. So here's the lesion. You can appreciate very deep calcium, but also a bit mixed tissue, fibrotic tissue. That's the final result following lesion preparation with a combined and hybrid approach. So in this case, there was a cutting balloon involved and a combination with an OPN. And then ultimately the procedure was ended with 1 DCB at the lesion site. And because there was some concern that about the significance of the residual distal stenosis, Florin decided to do additional FFR on top of OCT, which already ascertained him that there was good lumen gain, but that was not significant, and everybody is wondering how that healed over time. And here's the follow-up after 2 months, and you can see the images, and that case had already been published in a journal as a case report, and you can actually see how nicely those vessels healed. And we had really deep cracks, and they're actually reaching into the media, and following that, you see it's nice healing. Okay. So I'm finishing here now. Basically, we have many devices now on hand. If you see calcium in the near future and think of super high pressure balloons as a valuable option in your toolbox, calcium in general requires vigorous lesion preparation. What I also can't stress enough is use intravascular imaging, define the underlying issue, and pick your devices, and especially your device size, based on your measurements of intravascular imaging. Use dedicated tools, atherectomy, combine it with, if necessary, to deliver devices. Super high pressure balloons are certainly very popular devices at our side, but we also combine them very often with modified balloons or IVL if necessary. Avoid semi-compliant balloons for lesion preparation, especially in fibrocalcific lesions. Go back, and if you use the OPN at high pressure, we know that it can be safely used, and don't be afraid of dissections. Thank you very much.
Thank you, Matthias. Excellent presentation, and congratulations on completing a study. I know these are not easy to do, especially in this complex subgroup, and very, very provocative and very insightful results that you produced. So maybe we can start and ask Sanjit. You've seen this data. There's very little comparative data, as you know, for different calcium modalities. This is one of the few randomized trials. How will this going to affect your practice? And I know that Matthias said we don't want to show an algorithm because it changes, but at the end of the day, all of us have an algorithm in our head, right? So what is your algorithm, and how is this going to change potentially from this data you just heard?
So I think this is important because, essentially the SCAI consensus document says image, and then if you see, a high degree of calcium, ARC of 270, thick calcium, nodular calcium, you should use some sort of calcium modification. So what happens for me is now OPN NC can probably be considered a calcium modification tool in addition to IVL, in addition to atherectomy. I think the one caveat I would say is that, we do need to educate operators. In other words, image, make sure you go down by 0.5 millimeter size. And if you look at the compliance chart of the OPN NC, it does grow. So at 36 atmospheres, a 3.5 balloon becomes 4.0. And that's important to realize, because if you go 1-to-1 and then you go to 40 or 50 atmospheres, you're going to way oversize, and that's when you run into complications. If you're going to wield this device, know how to use it, image, and do it right.
That's a great point, and I think that was the protocol of the study, which I think is very well done and reflects the current practice, so you want to undersize. What do you do for instant lesions? Like, let's say you have an instant restenosis lesion. Maybe you can ask Stefan.
Well, I think you're pointing to an extremely valuable role of that technology, especially for, and I'll be covering that topic a bit later, but I think it's a very, it's where other tools have limitations. Doing the stentectomy or stent ablation, it's at the crossroad of interventional cardiology and auto body shop, so we're not quite sure if it's really viable as a strategy. Doing these, it makes more sense. You respect better what should be done on a stent. You want to re-expand it. And you know, we know shockwave is not extremely effective in terms of distributing the shocks behind the stent strut. So I think we deeply needed that type of technology for that indication. And to me, it's been very, very changing my practice.
Maybe one question for Alison. Are there situations where you downsize even more than just 0.5, or you, let's say, downsize by 1 millimeter the balloon?
So again, everything needs to be very much imaging guided, but maybe in the setting of eccentric calcification or nodules, I may start with a downsize by 1 and then upsize if required, just with a little bit more caution in case there's sort of a disproportionate push of the calcium in one direction. So that would be maybe one scenario where I would consider downsizing a little bit further. I'm going to talk about another technique later with small OPNs as well in a certain context. So.
But that's a very important point, and we're actually doing the same at our side. If you have those very oval lesions, then we would not measure or use the balloon on the length, the widest diameter. We would actually size it on the shortest diameter, just in order to ensure not to overstretch the vessel at the first.
And especially also, just as a final comment, in the setting of a ring, of a complete ring, then I don't size the balloon according to the vessel size, and I size the balloon according to the ring size, so the inner diameter of the ring. So I upsize, if the ring diameter is 1.5, then I upsize it maybe by maximal 1, and that's enough to crack the ring. And then you can go to 200 atmospheres. If the balloon holds it, nothing will happen.
Yep. Okay. Good. Thank you.
Right, well, wonderful again. Excellent, excellent work. We're going to move on to Dr. Charlie, who's going to talk about strategies when plaque modification fails in complex calcified lesions.
So I think all of us have been in the situation where we have a lesion that maybe we've rotated, maybe we've done IVL, maybe we've done cutting balloon, and it's still not yielding. And I think that's a situation where we really need to have, have guidance on what to do. So I'm going to show you a series of cases that were challenging that we had. So this is case 1, 52-year-old male, had an anterior ST elevation line a few weeks ago, came back for a stage PCI of the RCA, and you can see that there's a nodule in the mid-RCA, heavily calcified, and probably most people would say, you know what, this needs rotablation, we should go. But we operated based on the SCI consensus document of seeing if a 2.0 balloon can go down, cross it, and then image, and so that's what we did, and we had various options. And what you can see, this is the still image of the OCT, is that these were very, large nodules, and you can see there were multiple nodules throughout the RCA. And, our general approach is with nodular calcium, we don't know what the best approach, they have poor outcomes. We often will use either atherectomy or IVL. So that was our approach here, is that we used an NC balloon, and then we used a 3.0 IVL balloon, both proximally and distally. And I think one of the most important things is that we often assume that the tightest stenosis is going to be the hardest to dilate, and that isn't the case. Oftentimes, the worst calcium and the inability to dilate is remote from the 99% stenosis. So here we had a stenosis that did not yield despite 120 pulses in more of the proximal RCA, away from the target lesion, and then the question is, what do you do? And then we took an NC balloon and it still wouldn't dilate. So at that point, we decided to go to an undersized OPN, so we used a 3.0 IVL, then undersized to a 2.5 OPN. And you can see that there is some better expansion, and then we proceeded on, and you can see we imaged that nodule, and now you're starting to see that nodule pushed out of the way, so to allow stent expansion. And the area there is 7.6 even without a stent, which is quite good. And we then stented it, and this is the final result. And then let's look at the OCT, because you still see some residual stenosis there, and it looks like a kidney bean, but the area is 9 millimeters, right? And so the important thing is the most important predictor of outcomes is MSA. So MSA here of 9, great. And we talk about an MSA of 4.5 and 5.5 on IVUS and OCT. And so without this technology, we would not have, we probably would have stopped. We wouldn't have stented, this would have been challenging. Okay, let's go to another case. This case, full disclosure, is not my case, it's a colleague. And this is a 71-year-old male with a non-STEMI, prior cabbage, and had a prior stent to the circumflex. So already this is in-stent restenosis. The operator took a 3.5 NC balloon. You can see the 3.5 NC did not expand. They took a 3.5 IVL balloon, and the 3.5 IVL balloon did not expand despite 120 pulses. They did not image either before or after. And they ended up putting a drug-eluting balloon, a 3.5/20, which doesn't look so bad on angiography in one view. And then this is the final result. You can see there's a residual stenosis. I honestly don't know what the area is because it wasn't imaged. But what happens once comes back again. So the patient 5 months later was readmitted with unstable angina, has recurrent in-stent restenosis, not so very surprising. The next operator said, you know what, we're going to image this. And what they demonstrated was severe calcified neointima within that area. And we're talking about lumen area of 1.25. And they decided to take both an NC and then a 3.5 IVL. The 3.5 IVL, so IVL may be less effective when you've got a stent in the way, as Stefan's going to talk about, but this did not expand. And I'll show you and then they went and proceeded, put it in a stent, hoping the scaffold will keep the artery open and expand it. And then I'll show you, this is the stent, there's still a waste on the stent. And then look at the longitudinal profile. And you've got a luminal area of 4 and only 60% expansion. So, this is severely underexpanded. It's already had multiple restenosis. If you leave this alone, this patient is almost guaranteed to come back. And you've tried cutting balloons, you've tried IVL, you've tried NCs. What is there to do? And so I was asked, my opinion, and I said, you know what, I think we should use a OPN in this particular case. And this was, we undersized it. We used a 3.5 OPN. And the luminal area went from 4.1 to almost 9 millimeters. So, for me, this as a therapy, every cath lab should have it on the shelf. For this particular scenario, you can't dilate the stent and you have no other options. You don't really want to rota or orbital out the stent. That's almost traumatic. But this is a simple intervention where you can optimize that stent. Okay, next case. So full disclosure, this is not my case, and this is actually a Victory case. So 74, so Victory randomized OPN versus IVL. Symptomatic CCS class 3 angina, very heavily calcified RCA, very tortuous as well. This was balloon uncrossable, so patients were allowed and were randomized after atherectomy in the Victory trial. So this patient ended up having atherectomy. Maybe that guide should have been something other than a JR4, but anyways, they did proceed. And this is the OCT. And what you see on the OCT is the orange bars represent severe calcium, and you can see severe calcium in that segment following a rotational atherectomy. And clearly, this likely needs further calcium modification. So patient was randomized within the Victory trial to IVL and ended up actually having 3 different IVL balloons, and they kept on rupturing, likely related to some nodular calcium. And despite rotablation prior to this, and I guess the question is what to do. This patient ended up being a crossover to OPN NC. So actually first they took a non-compliant balloon, that ruptured, standard non-compliant, and then they took an OPN NC, a 3.5 OPN at 40 atmospheres. This ended up opening, and what you see, this is the final stent result, and the following is the OCT result, and you can see the luminal areas are very, very good in that proximal segment, luminal areas of 12, 13, 14. So, this patient actually should do fairly well. There's a little bit of malposition proximally, which I'm sure they fixed. So in conclusion, OPN NC is an essential tool in the cath lab, particularly when other calcium modification fails, whether it's orbital, IVL, cutting balloon. And it's particularly useful, as Stefan's going to get into, for stent under expansion. And I think particularly in stent under expansion probably works better than any other device on the market. So I think every cath lab should have it, and if you don't have it, you should get it. Thank you.
Thank you, Sanjit. Again, phenomenal cases and a lot of challenging situations without many options. I mean, the case you saw, what's the next step? Rotablation again, you've done rotablation again. Laser may not work as well in calcium, so really you're out of options at this point. Maybe we'll have, maybe Alison, if you want to talk a little bit about the logistics and the wire choice, because something we haven't talked about, and that's important because some wires may not work as well for OPN. I don't know if you want to walk people through that.
Yeah, absolutely. So that's a really important point, in fact. So some of the common workhorse wires actually have significant friction with the use of OPN, and when you go to withdraw the balloon, if you work on those wires, your entire kit will come out, or very often it will. So one of the worst culprits is actually the Sion blue wire, which is very commonly used, and so it's something that's important to be aware of. So generally, I would recommend either using a wire that you know is having less friction associated with it, or putting a buddy wire down when you're going to use OPN, and that way you know you're not going to lose your vessel access. So it is a really important consideration. There's a good paper published about it, actually.
So Alison, what do you use? What wire do you use with an OPN?
I use a couple of things. I tend to use a run-through extra floppy a fair bit, and sometimes a regular Sion as well, but occasionally it still sticks a bit to that. But Sion blue is by far the worst culprit I've found.
Yeah, we tend to use the BMW, and it's pretty good in terms of not having a lot of problems with sticking.
A good balloon, just maybe a good wire in such cases is the Grand Slam wire, because it's a heavy support wire. So if you do an RCA like that, even if you have a JR4, which is maybe not the most supportive cut, but I think if you have a very supportive wire, then you can still deliver. Because the next question maybe for you, Sanjit, is how do you make sure you can deliver the OPN? Do we always need to rotablate, or do you people who haven't used a lot?
Yeah, so I think the elephant in the room is that the OPN NC is a bulkier device. And so our general approach, particularly in difficult or tortuous anatomy, is you come in prepared. So we may use a 7 French guider. We may use an AL1, particularly in the RCA. We use liberal use of guide extensions. And you may need to balloon anchor your guide extension to deliver your OPN. But I think it's important that that's not uncommon. IVL, I mean, we'll see with the Arrow, which is supposed to be more deliverable, but the prior versions of IVL were still also fairly bulky. So you need to be prepared. This is not like a regular semi-compliant balloon to deliver. And
I think that's a very good comment. And I think one of the things which we should probably do more is to open a 2.0 balloon without the intention to crack everything, but just to create some space for the OPN, and then deliver the OPN.
Yeah, and then Stefan, obviously you're going to talk about the instant in a few minutes, but in terms of algorithms, we talked a little earlier about algorithms and when to go and when to use what. What is your typical sequence of modification devices in these heavy concentric calcified lesions? And does it matter if it's in-stent versus not in-stent?
Yeah, I think it's your first of all, my algorithm is it depends on how severe the lesion is, and can I image first or not. If I suspect that an imaging catheter will not be able to go, usually atherectomy will come clearly in my mind in these situations, because you're dealing with a very, and it's better in my experience to do atherectomy as a first strategy than a bailout strategy. So usually in these situations I will be thinking about, and you know, for me, I'll be frank and honest, I think the place for orbital atherectomy is in interventional cardiology nowadays is on the shelf. because I've seen too many perforation, and I am not a big fan of orbital. I really prefer using ROTA. So I will use ROTA in these cases. Then afterward, if I can't image, then I will sort of, and if I could deliver an image catheter, then I will choose based on the distribution of the calcium and everything. And with the Eclipse trial, we see that a lot of these lesions can actually crack, right? So we can actually modify them with balloon angioplasty. So I think once you've committed to balloon-based strategies, you don't pay you don't have a toll by trying a regular NC balloon. So that's my approach. And then that the regular NC balloon behavior is extremely informative beyond just the IVUS. Is it expanding well? Is it expanding eccentrically? Am I pushing the nodule aside? Am I just taking expansion of the healthy wall, especially when you have eccentric calcium? That will guide my sequence of things. So difficult to understand. I'm just trying to tell you why my algorithm in my mind and how I will address that. But definitely now with IVL and with all the balloon-based strategies, and including OPN and including scoring balloons and cutting balloons, we have more tools to address plaque preparation and also reassess if we've done the modification. I think it's very important. One point that I wanted to say at the end is that I think it's one of the IVUS is the most important, is the one you just do prior to stenting. I think this one is the one that you should really do, because that's the one, or OCT, or the imaging run just before you commit to stenting, because that's going to be the moment where things may go more difficult. So.
I just want to add one other thing, is that we had a core lab that assessed fractures in Victory, and the rate of fractures was not different. And what you typically see is you see about 60% fracture rate with IVL therapy, and we saw similar with OPN NC.
Do you think we have sensitive enough technology to actually see all the fractures and their depth and everything? And do you think that might be also a misclassification because we don't have the way to see if maybe IVL is doing some fractures that you cannot see?
Yeah, no, absolutely. I think we do know that.
Can I counter that? I like to be a bit provocative. Do you think fractures really matter? Because at the end, if you implant a stent, I think probably the better test than looking for fractures on OCT or IVUS is just to open a balloon in 1:1 size and check if the balloon opens up. And then I don't really care if there are microfractures, superfractures, great fractures. If the balloon opens up, then it's fine. If the balloon doesn't open up, then you have to do some more work to do. I mean, this is a very provocative statement, I know, but I mean...
Yeah, no, I think it's important because when they look at micro-CT, OCT will miss about half of the fractures, number one. Number two is that in Disrupt CAD, Ziad has published that fractures were not predictive of MSA and expansion. So it's nice to see fractures, but oftentimes you will miss them. And I think the most important thing is you can get your stenting well expanded.
Yeah, but I think if I missed, right, in Victory, the expansion was the same. So
Yes.
end of the day, what you're saying doesn't matter. You see them, you don't. End of the day, you do get the same MSA in the end. So.
The only thing I would say is that if you don't see fracture and you see your balloon expanding, doesn't mean that you'll be very satisfied with your stent, because stent recoil is something that happens. We've all seen balloon being beautiful, and then you place a stent in front of a nodule, and then afterward they don't look so good because there's stent recoil and there's impinging on your lumen by the stent. I'm not saying that we necessarily know what to do with these. Maybe we're turning this nodule to be angrier and angrier by hitting it more and more. But I'm just saying that I think it's reassuring to see also that by IVI, you've modified the plaque beyond just, I think they're complementary. I'm just saying, it's not provocative to me what you're saying. I think it's very valuable what you're saying, but they're complementary.
One thing I've barely ever seen is a fracture of a nodule. I do extensive OCT imaging in every case I treat, and I bloody hell, I don't see these fractures on the nodules with neither technique. So I think, even maybe you can crush it, but really to fracture the nodule through the middle, this 3 millimeter thick nodule, I don't know. I don't see that. Do you see that?
No, we don't, but I must admit, personally, I don't do very high pressure on nodules because I'm concerned I'm going to push the nodule out. But maybe, in the interest of time, otherwise we're going to have let's move on to Dr. Hall. So Dr. Hall is going to talk about pre-cracking the plaque technique as an approach for tight and complex lesions. We talked about undersizing by 0.5, but maybe undersizing even more for these very tight lesions may be another way to go.
Okay, thank you very much. So pre-crack the plaque technique. So we're seeing, as we've been discussing, increasingly we're using OPN as an upfront plaque modification tool. So just want to show you another way that we may be able to use it in very tight lesions. So the concept is if you have a significant stenosis, say, 90%, 95% stenosis, your initial lumen diameter right at the point of that narrowing is anticipated to be pretty small. So in that moment, you can take an OPN and size it to that lumen size, which could be 1.5 millimeters, 2 millimeters, et cetera, and comfortably inflate that balloon up to 40 atmospheres or more. And thereby you initiate an initial potent force that's delivered to the contact with that lesion, initiate some initial fractures and plaque modification, then go in with your NC balloons and further expand those cracks and that modification, and subsequently place your stent. This is something that would be performed under imaging guidance to ensure that you're achieving your goals at each step. And then, of course, you verify your stent result. This is just a schematic to give you an idea of what I'm talking about. So again, if you have a tight, ideally like a ring of calcium or a somewhat calcified plaque, you inflate your OPN to high pressure initially at the lumen size, initiate these microfractures or small fractures, and then follow with the NC balloon, further modify, get expansion, and place your stent. So I'll show you some cases where I've tried this technique. This was a younger woman with multiple cardiac risk factors and anginal symptoms in the community initially. She had a CT attempted in the community, and there was significant calcification in her LAD. And in fact, in general, there was, and they abandoned the CT in terms of further diagnostic information. She got admitted to hospital with unstable angina ultimately, and this was her coronary angiogram. So a series of very tight tandem lesions in her mid-LAD. So on the initial OCT run, the images were not perfect just because it was a really tight narrowing, but you can see a very tight stenosis with a lumen measuring something around 1.5 millimeters in size, a decent ring of calcium, and up to a thickness of about 0.5 in places. This was the proximal lesion, which I didn't see well on the initial run. It was just a poor OCT, and then the distal reference vessel. That's around a 3 millimeter size. So I went down to the distal lesion with a 2.0 OPN and inflated it to 40 atmospheres. And these are the OCT images following that inflation. You can see initial cracks developing in the calcium and initial plaque modification. At the proximal site, you have some similar findings. And then I took down a 3.0 NC to the distal lesion. You can see you're getting further lumen gain and additional expansion of those fractures and modified segments. And proximal lesion is changing a bit as well, maybe not as much. And then a 3.0 stent was placed and further dilated with 3.75 and 4.0 NC balloons at the distal lesion site. And this is some examples of the appearance of the result at that site. So you have good areas there despite some, D-shaped findings in some of the shots. The proximal lesion appearance was good after placement of a 3.5 stent and dilation with a 4.0 NC. And just to show you some co-registration images, so this would be the initial distal lesion appearance on co-registration, and this is that same region following the treatment with the OPN and NC balloons. These are some other examples of the finished product at that site. And this was the final angiographic result, and the patient has been doing well clinically. This is a second case where, of course, we always want to be imaging guided, but I couldn't get an IVUS into this vessel readily. And basically, I took initial small balloons just to create space as we were talking. And I passed down a OPN 2.5 millimeter balloon, inflated to 35 atmospheres, and subsequently was able to advance NC balloons and stent the vessel. And this was done with a good safety margin without imaging, just based on the nature of the vessel. This is a more elaborate case, a gentleman, 79 years old, who came in with an NSTEMI and initially they were attempting conservative management due to his comorbidities, but he had ongoing symptoms and a significant burden of ischemia on his myoview. He had significant renal impairment in particular, which was why they initially hesitated on cath. But ultimately he was cath, had multivessel disease, discussed at rounds and turned down for surgery. And the plan was just to deal with his right, which was a large vessel in the territory that was lighting up on his myoview. They thought it was a CTO initially. When I brought him to fix it, it was kind of a subtotal occlusion there. And this was the pre-IVUS. So it's not a terribly heavy burden of calcium there, but you have a thick mixed calcified plaque there. And I took down a 1.5 OPN to that tightest spot of the lesion, and you can see some very small initial fractures that were generated after inflating to 35 atmospheres. I further dilated then with a 3.0 NC, and then with a 4.0 NC. And you can see now on IVUS you're getting, increased modification at those fracture sites. And I deep-seated a guide extension and was able to place 2 drug-eluting stents to that prox to mid-vessel. But now I have these distal lesions as well, one in the PL and one in the PDA. So I tried the pre-crack technique again. You don't really want to push an imaging catheter all the way down there. I mean, you could, but I put a 1.5 OPN down there, inflated it to 35 atmospheres, and did further dilation with NC balloons, and placed a stent successfully in that upper branch. I then went on to the PDA and used again the 1.5 OPN up to 35 atmospheres, followed by a 2.5 NC, and placed a stent in that PDA as well. And you can see here the final angiographic and IVUS-based results, which show nicely expanded stents and no ill consequences for the patient. So, in terms of pre-crack technique, a small balloon may go where other larger balloon-based devices may not travel, especially after you dilate with even smaller balloons potentially. You don't need any adjunct equipment. It's efficient and cost-effective. Anyone can do it without additional training. OPN does have good safety data obviously available now, but this may further improve the safety margin when you start with that smaller balloon, especially for operators who are newer to the device. You can perform unlimited inflations, cover any length of vessel with the balloon, of course. You do have to use a compatible wire, as was discussed earlier. Limitations, well, of course, it has to be a balloon crossable lesion, as was said, so otherwise you're getting into a rota situation. Its efficacy in, very thick and eccentric calcification may be somewhat more limited. And this is not a direct comparison towards an NC balloon, so in some cases, as Stefan said, of course, an NC may be equally effective. And we don't know exactly how much you want to be downsizing the OPN here. The only downside is if you undersize initially and you don't get enough modification, you would have to size up at the cost of an additional OPN device. So I did actually just publish this as a case series in CRM if you want to read more about it. So thank you.
Thank you, Alison. And again, great cases. And I agree with you that the safety profile is good, the meta-analysis and the perforation rate was very low, but this will make it even safer because you don't have, essentially the probe almost eliminates the risk of perforation. Just curious, Sanjit, Stefan, Matthias, have you guys used these small OPNs balloons? Do you still use like a Sapphire? How is your algorithm for this very tight calcific lesions, but in a smaller kind of vessels?
I mean, Florian, please correct me if I'm wrong, but one of our preferred approaches is actually to use a very small semi-compliant balloon. In the majority of cases, it's still the oldest balloon on the shelf, the Maverick. And then following that, we would use in those super tight lesions a 2.0, 2.5 maybe, and yeah. And again, like we didn't stress that out. But I think 95% of all our procedures involve the cyan blue at our site, and we, in those super tight lesions, or whenever we are concerned that we could lose the wire position, we actually place a lifeline, we call it, meaning an additional wire. And then this provides you on one hand support, and then if you pull it out with the OPN sticking to the wire, you still have a line down there. But what we also learned over time is actually that you should give the balloon a bit time to deflate. And the majority of us interventionalists are a bit impatient because you go up, go down, and just want to pull it back very fast. But if you leave it 10, 15 minutes and to have it completely deflated, nowadays with the latest generation of the OPN, it regularly, in the majority of cases, it no longer sticks. That's our experience.
And just one shot. Maybe, Matthias, when we do cases together, one parameter of how much you have modified the plaque is to really look how the inflation device responds. So you inflate it, and then usually Matthias said it's too small. It's not effective. You can go to 100 atmospheres, but if the plaque is already cracked, then we don't go higher. So I think for those of you learning with the OPN, try to learn to interpret the feedback you get from the inflation device. That's a very, very important feedback, which is almost as good as imaging, I would say.
For those of you who have not used OPN, it does not use the regular inflating device. You use a special device that can go to high pressures, so it's a different thing, but it does provide you feedback, and exactly what you've heard from Fiore.
I want to share a little trick that it's something that I've used for vein graft as well, and I mean, this is when you have an interaction with your balloon and your wire, one of the problems is that your fingers are not strong enough to maintain the wire in position. So one way to overcome that, which is very simple, is to take a torquer and to bring the torquer and to lock the torquer at the 2E level. And then you pull, so then the wire cannot come back. Then you pull on your OPN, and you'll be able to bring the OPN. And as much as when you initiate that movement, then you can walk out your OPN on the wire and not lose your wire. So if you face that situation, bring a torquer, lock a torquer at the level of your 2E, and then your wire will not move. You just pull on your OPN and you get it out.
Yeah, great point. I think on the inflating device, if you're seeing the dial keep on going down slowly, that means you're still modifying. So keep the pressure up until you see the dial kind of staying where it is. That's a kind of a poor man's way to seeing that you're achieving still plaque modification or not.
I was just thinking of one thing too. I guess if you're using a buddy wire system with your OPN, it's almost like a poor man's cutting balloon then too.
Also, yeah.
Exactly. All right, well, again, last but not least, Dr. Rinfrey is going to talk to us about what to do after stent under-expansion and in-stent stenosis. 15% of cases are ISR, and these are often some of the worst ones to get them expanded.
All right, so thanks for inviting me to this very, very useful and practical session. And I think for operators who are not used to this, it's extremely helpful. So, tool and to understand in your daily practice. I think we need this balloon because IVL does not always work alone and needs adjunctive therapy. And chronic or acute stent under expansion is common and often difficult to treat. There's really limited effect of IVL beyond stents, and you need a safe solution to those common problems in complex PCI. But the truth is, we need multiple tools in complex PCI to achieve best results. Sometimes it will be atherectomy, IVL, scoring balloon, OPN. Now we have new trials that challenges which you should be using first or second, but in the end, all these tools have proved to be helpful. Now so the question will be coming about what should you use first or instead, but the reality is that there's a lot of things that we maybe are going to be better at deciding what technology to use in which situation. And for old expanded stent or fresh under expanded stent, we know that IVL and ROTA is certainly not the best approach, and having a tool to expand the stent is definitely a game changer. So IVL does not always work alone and need adjunctive therapy. Here's a case that I did last year, CCS class 2, post-LED PCI. He's had a SAVR or radial. It was a real painful radial case. Here, we have a severely underexpanded stent at that level, and the IFR is positive in both branches. So we have an indication the patient has class 3 angina, it's positive IFR, and we start to treat. And again, here we got a guideliner. We're starting with an NC balloon, and you can see just the behavior of the balloon is not satisfactory. I'm at 20 atmosphere. I bring NC balloons frequently up to 25 atmosphere, acknowledging that they grow. And this is the IVUS after crossing, and I knew I could not deliver. So it's a complex anatomy of neoatherosclerosis, so you can see calcium within the struts, and therefore it's going to be a difficult situation to treat. The minimal lumen area is bad, so therefore you will want to do something, IVL, and guess what? It's not expanding. In our place, because I work in the United States and reimbursement is something, at the time we had for our patients some reimbursement for IVL, and it's one way to overcome some of the cost that could be associated with the use of OPN. So in our center, we had a policy that we had to try IVL first before pulling the OPN, at least to get the revenues that are associated with the IVL. So I tried and didn't make any difference, but I can show you here the difference. This is a difference between IVL at the same diameter and OPN. The OPN clearly expanded. The stent really expanded at this point. I went to 45 atmosphere, got a very good result. And then afterward, it's getting better. I'm doing an IVUS. I see that I've cracked and I have better penetration beyond the surface of that calcium. And then used an NC balloon. I still like scoring balloon. I think you can choose whichever scoring balloon you prefer, but I think they can be extremely complementary in these cases. And after we did IVUS, and now you can see that there are this inside of that ring of calcium within the stent, it's now expanding. So I am in a better situation to sandwich it and get it done with the stent. And then we finished. We got a good result, and everything was well expanded now. So lots of tools. Try to understand what is the mode of failure was very important here. Another case here, 85-year-old non-STEMI, heavily calcified RCA. This is a case of one of my colleagues. So you can see that there's multiple areas where there's a stent. You barely see the stent right there, but believe me, there's a stent in the mid-RCA. And then there's their NC balloon there. And then finally, the IVUS doesn't cross because we have Phillips IVUS, so therefore it doesn't cross. And you can see that this vessel is at least a 3.5 vessel proximal. So going down with IVL, this is the result of IVL. The balloons are not expanding really well. And then the control angiography may look reassuring. And I think it's, so a short oversized balloon doesn't get, and then there's a clear undersized, oversized, clear, waist and like stent regret sign right there. So oversized balloon, and then at the end, the control, he feels that he got it, and then try to do an IVUS, doesn't cross the mid-segment. That should have been a sign in itself. And that is, goes back with an NC balloon, and we get this. The patient comes back with a non-STEMI. And this is, so the patient gets in the room. So this is 10 days later. Now I want to this is a deep OCT with spectral wave. And you can see the amount of calcium. And I want to show you how this level of quality of image tells you exactly what's going on. You can see now a lot of calcium around. You see the stent right there. And here, even Stevie Wonder could see an underexpanded stent right there. So this is absolutely no doubt that you have a problem right there. So we go with a guy liner, an OPN 3.5, delivering. So you got to be ready to deliver this balloon. It's not going to be easy. And then at 45 atmosphere, that expanded just beautifully. We re-expanded everything and got a very good result. The OPN, use a 4.0 at the end because we sized the vessel. Now at this point, we can expand and mold the stents to what we want to do because we've already cracked the main issue that we had. And then and a final OCT. And this is on the left, you've got the distal, and on the proximal, you've got the distal. And you can see now that, of course, there's a lot of disruption of all that calcium behind, but there's no new stent. And all the stents that were recently implanted are well expanded with good areas. So this is the final result angiographically. So OPN can achieve stent optimization in several scenarios where other therapies have failed. So NC balloon, atherectomy, IVL, and honestly, I think nowadays, this is my go-to for an ISR case, and we're sort of putting we're not going to use this IVL rule anymore. We really don't think it makes sense. We feel it's better for ISR to an underexpanded stent to just use that device and get more efficient. Thank you.
Wonderful. Thank you. Thank you, Stefan. You have a few minutes to have a little discussion. I mean, Fiorim, you've done millions of those cases, and you had using it for many, many years. Do you think it works better, even better in ISR, or what is your thoughts about ISR specifically with the OPN?
In ISR, I think it's extremely important to size even more conservatively. So the pre-crack the plaque, I would apply that. So if it's a fresh stent and it's severely underexpanded, like the one he showed, so I found the 3.5 balloon, in my opinion, actually almost too big. So I would have might even have gone to a 3.0 balloon and just go to a very high pressure, because I think in ISR, if you have such a stent, you really have to crack the ring first, and I would do that the same with the downsizing, because the problem is also sometimes you don't see what's behind the stent. So if you use a too big balloon and you have a big calcium nodule which didn't allow the stent to expand in the first place, then you can really rupture the vessel. So the worst ruptures I've had have been usually in stents I've post-dilated. So that's why I've become more cautious to go more conservative.
Are those for fresh stents or for old stents?
Sorry?
Are those for freshly placed stents just recently or for old stents?
I'm always, the older I get, the more conservative I get, so I always downsize even more, because I can always take a new OPN NC, which is, of course, a bit more cost, but it increases so much safety for me, so I'm a downsizer.
Any other last-minute thoughts, Sanjit?
Yeah, I mean, I think it's important to remember IVL is off-label post-stent. So, Stefan, the recommendation of your center was not, it's off-label, and so I think the OPN NC is a very valuable tool for in-stent restenosis. Kevin Kroos, who probably does some of the most work in the country, uses tons of OPN NC, and he says it's such a valuable tool. Do you want to laser a stent on contrast, or do you want to just do a 30-second OPN NC and get that stent expanded?
Yeah, totally believe you're right, and the simplicity of the device. So I want to come back, to your comment, Florim, regarding undersizing. Of course, there are cost consideration and everything. So, is there any way someone can what would be your rule? Because the company and they're telling people to use a 1-to-1 sizing for in-stent. You're sort of saying you're to be cautious about that. Is there still a situation where you could reassure some people that 1-to-1 is reasonable? Is it the amount of calcium that's around? Is there something else we can learn from that?
So in a general rule, I think if your stent expansion is less than 50%, like you had in your case, then to go 1-to-1 is, in my opinion, dangerous. Okay. I think if your stent expansion is 70% and you want to optimize that to bring it up to 80%, then probably 1-to-1 is fine. Okay. But I think if it's severely underexpanded, then I really, in those cases, I'm very cautious. Maybe Matt can complement.
No, I'm fully couldn't agree more with you. But even like having angio as a device to size, or actually information to size, even then, it's often if you have newer machines like Philips or so, you can still measure the vessel by just doing QCA and size your devices according to QCA in many cases. That's what we do in real world practice as well, actually. We don't have 100%, at least in our hospital, we don't have 100% uptake of image every lesion prior to PCI. And
maybe just one comment for the younger under you. So if your 3.5 stent looks underexpanded angiographically, then your diameter is not usually 3.3. mean. Your diameter is 2.7 or 2.8. So then with a 3.0 balloon, you can bring your diameter maybe up to 3.3, and then it will look fine, because maybe you are just overestimating the vessel. Because that's what I said before, the most perforations I've had in my life is always in postulating stent. And this always because I was way too ambitious with this. So I think imaging is important, but if you don't have it, rather downsize it to increase safety. This is the take. And I think with Victory, the safety profile of Victory is because we really consequently downsized our balloons, and then we didn't have perforations.
Did you have instant in Victory, or was the novo?
No.
Okay.
That's Victory 2 format.
Okay.
All right, there you go. I guess it's a pre-crack, Alison's pre-crack in a different mode for the instant.
Yeah. I think, too, when we talk about one-to-one, you have to remember what you mean based on the compliance charts with the balloon, too, because if you're going to extremely high pressures, you know, if you're thinking you want a 3.5 balloon and you've taken a 3.5, you're going to be above that. So if you take a 3.0, you'll get closer to your 3.5 goals. So you have to factor that in as well.
Yeah, on that super underexpanded stent, I used the size of the stent. It was a 3.0 stent, but this stent was undersized because the vessels was 4 over there. So I think sometimes also those situations, the diameter of the stent is also pointing towards what could be the right size of your balloon, because it's often an underexpanded stent, and a lot of people who are not using necessarily, were not able to image. It's rare that they will have grossly overexpanded that area with the stent. So it's the way, it's one way that I would interpret that, and also based on the rest of the imaging you can gather from what has been done in other segments. But there I think it was just grossly underexpanded.
But I guess the bottom line is, for these cases, imaging is going to be happening in pretty much universally. So I think we're a few minutes over, but again, thanks everyone. Thanks the panelists, thanks the presenters, the audience. Thank you so much. I'll be around if there are any questions. And I think it's a very good device. I think we'll agree. And with Victory now, there's much more data behind it. Thank you so much.
Thank you so much.